Welcome to the Deep Dive, where we sift through stacks of information to bring you the most essential insights.
Great to be diving in.
Today, we're plunging into a condition that can, well, send shivers down the spine of any horse owner. Laminitis.
A really tough one.
Imagine your horse, usually a picture of grace and power, suddenly in excruciating pain, barely able to move.
It's incredibly distressing to see.
And this isn't just a limp. It's a sudden, severe lameness that can escalate incredibly fast, often forcing that heartbreaking decision: euthanasia.
It is. It's a complex and painful disease, and it truly doesn't discriminate.
No, it doesn't. From a gentle family pony to an elite athlete, any horse can be affected.
Exactly. So for this deep dive, we've pulled from, specialist-level studies and comprehensive overviews, all focused on equine laminitis, often referred to as hoof failure.
Hoof failure, right? Heard that term.
Our mission, basically, is to extract the most important nuggets of knowledge, how we understand it, how it's diagnosed, and the contemporary strategies for managing it.
And whether you're a horse owner, an equestrian enthusiast, or maybe just someone who loves learning about the intricate workings of the natural world, you're going to gain a foundational understanding of this critical equine health issue.
Along with some truly cutting-edge insights into treatment and long-term care.
Definitely. So let's unpack this. At its core, what exactly is laminitis? We hear hoof failure. What does that mean?
Fundamentally, laminitis is a painful, inflammatory, and degenerative condition affecting the sensitive laminae of the horse's hoof.
Okay.
It's a failure of the critical support system for the distal phalanx, that's the P3, or coffin bone, which is suspended within the hoof capsule.
Suspended?
Yes. Essentially, the strong mechanical attachment between the hoof wall and that bone just gives way.
Wow. That makes sense. But how does that attachment normally work? What makes it so incredibly strong?
Well, the hoof wall and the P3, the coffin bone, are mechanically attached by these amazing interdigitating structures called laminae.
Interdigitating, like fingers locking together.
Exactly like that. Or think of it like industrial strength Velcro, locking together really tightly. You have one set of these fingers on the insensitive hoof wall.
The hard outer part.
Right. And another set, which is sensitive and richly supplied with blood and nerves, on the coffin bone itself. This interlocking is what provides that incredibly strong mechanical bond.
Allowing a horse to bear enormous weight and move with such power.
Precisely. It's quite an engineering feat.
Ah, that's the aha moment. That interlocking system is absolutely crucial.
It really is. And at that critical interface where these fingers connect, you have something called the basement membrane zone, or BMZ.
BMZ. Okay.
Think of it as the super strong molecular glue holding those interlocking structures together at a microscopic level. Very important.
Okay.
And these sensitive laminae also have a complex network of tiny blood vessels, including special shunts, arteriovenous anastomoses, or AVAs.
AVAs.
Yeah, they regulate blood flow within the hoof. It's a beautifully engineered system, but as we'll see, it's surprisingly delicate.
Okay, so we know what's supposed to happen and what's failing. But how does it all start? What triggers this lamellar cascade you mentioned, this thing that leads to such devastating damage?
Right, the lamellar cascade. It's indeed a multi-step process, almost like dominoes falling. It begins with an initial insult that triggers either, systemic inflammation or metabolic dysfunction in the horse's body.
So not necessarily starting in the hoof itself.
Often not. In what we call the systemic phase, common triggers include a widespread inflammatory response. This can come from, say, endotoxins released from severe colitis, or maybe a horse getting into way too much grain.
The classic grain overload scenario.
Exactly. Or a mare retaining her placenta after foaling. These situations activate body-wide inflammatory pathways.
So it sounds like the hoof is often just the target for a problem starting elsewhere in the body.
That's a crucial distinction, yes. The hoof becomes the weak link where the damage manifests. Another major systemic trigger is sustained high insulin levels.
Insulin, okay.
Also known as insulin dysregulation, or ID. This is particularly common in conditions like equine metabolic syndrome, EMS, or pituitary pars intermedia dysfunction, PPID.
Often called equine Cushing's disease, right?
Correct. These high insulin levels directly impact those delicate lamellar cells and the microvasculature we just talked about.
Damaging the connections.
Yes. And also, excess glucocorticoids, think steroids, whether they're produced naturally by the horse due to stress, or PPID, or if they're given as medication.
Ah, so iatrogenic caused by treatment.
That can happen too. It can also initiate laminitis.
And I imagine mechanical forces play a role too, like uneven weight bearing.
They absolutely do. Excessive, prolonged weight bearing on one limb, often because of severe lameness in the other limb that's supporting limb laminitis, leads to microtrauma and stress in the laminae of the good leg.
Because it's taking all the weight constantly.
Right. The hoof is designed for cycles of loading and unloading. When one limb is constantly overloaded, it can suffer profound damage due to lack of blood flow and reperfusion injury when weight shifts slightly.
So what happens then inside the hoof once these systemic issues start? This is the developmental phase, you said, before we even see lameness.
Yes, this is where the damage truly manifests at the laminar level, often silently at first. And what's really insightful here, a key takeaway from the research, is that regardless of the initial cause,
Whether it's inflammation, insulin, steroids, mechanical.
exactly, the earliest and most fundamental damage seems to be this loss of normal epidermal basal cell adhesions. Basically, the hoof's crucial anchor cells start unsticking.
Like the Velcro coming undone or the glue dissolving.
That's a good way to picture it. The molecular glue holding those interdigitating laminae together starts to fail.
How does that happen?
Well, one major factor involves enzymes, the body's own natural cleanup enzymes called matrix metalloproteinases, or MMPs.
Yeah.
They become overactive in the lamellar tissue. They start breaking down the very connections that hold the hoof together, sort of uncontrollably.
So it's essentially a self-destruct mechanism triggered in the hoof. That sounds incredibly destructive.
Right. It is. And alongside that, you get cellular dysfunction. Those crucial lamellar epidermal cells, the fingers on the hook wall side, they get damaged or even die.
Okay.
Especially with metabolic laminitis, we know the excess insulin directly interferes with these cells. It overstimulates certain growth factor receptors, disrupting their normal ability to stick properly to the dermal fingers.
So the insulin itself is toxic to those cells.
In those high concentrations, it disrupts their normal function and adhesion, yes.
Yeah.
And while we used to think blood flow problems, vascular issues were the primary culprit, especially in metabolic cases, we now understand that these cellular and enzymatic failures are often the root cause. Vascular changes definitely happen, but they might be more secondary in many cases, particularly the metabolic ones.
That's a big shift in understanding.
It is. Of course, inflammation is still a major player. You get cytokines, reactive oxygen species, all contributing to the laminar inflammation and damage.
And for that supporting limb type, is it different?
For supporting limb laminitis, the thinking is it's largely due to ischemia, lack of blood flow, because the lamellae are constantly compressed under the increased load, and the normal unweighting cycle that pumps blood doesn't happen.
Makes sense. Just constant pressure.
Right,
So it's a widespread assault on the hoof's structural integrity.
right.
Given all these different triggers, how do veterinarians categorize this complex problem to make sense of it all?
That's a good question. It's clear there are so many ways this can start. Vets typically categorize laminitis into a few main types based on the underlying cause. Makes treatment planning easier.
Okay. What are they?
First, there's systemic inflammatory laminitis, or SIRS-associated laminitis. This is often triggered by things like that carbohydrate overload we mentioned, horses getting into grain, or too much lush pasture with high fructans causing gut problems.
Right. The hind gut gets upset.
Exactly. Hindgut dysbiosis. It can also follow severe colitis, retained placentas, or other major systemic infections like Potomac horse fever, basically severe body-wide inflammation.
Okay, so that's the whole body inflammation type. What's next?
Second, and this is a huge category now, is endocrinopathic laminitis, metabolic laminitis.
The insulin connection.
Precisely. Intrinsically linked to insulin dysregulation, like in equine metabolic syndrome, EMS, which often involves insulin resistance, obesity, maybe that characteristic crusty neck, and also seen with pituitary pars intermediate dysfunction, PPID. And importantly, as we mentioned, it can also be induced by giving certain steroid medications, exogenous corticosteroids.
That explains why vets are often cautious about giving steroids to susceptible horses, right?
Exactly right. High risk. Third is mechanical overload laminitis, or supporting limb laminitis. We touched on this severe lameness in one leg forces prolonged excessive weight bearing on the opposite sound limb.
Poor horse.
It's a tough one. Then there's traumatic laminitis, sometimes called concussion laminitis, caused by acute severe trauma directly to the feet, like, excessive riding on very hard ground. Road founder, historically.
Okay. Any others?
Finally, toxic laminitis. This can occur from ingesting specific toxins. The classic example is black walnut shavings used as bedding.
Oh, wow.
Yes, the heartwort is toxic. Or certain plants like Horiolisum. It's also worth noting that pasture-associated laminitis can be a bit complex. It might involve elements of both the endocrinopathic and the systemic inflammatory forms, depending on the horse and the pasture.
Okay, that covers the why. So once it starts, does it progress in distinct stages? You mentioned a hidden timeline of damage.
That's a great way to put it. Yes, we absolutely recognize three main phases, almost like a timeline the disease follows, even before we see obvious outward signs.
What's the first phase?
The developmental phase. This is the time from the initial insult, the grain overload, the retained placenta, whatever it is, until the first clinical signs of lameness appear.
So damage is happening, but the horse looks okay.
Exactly. Subclinical damage is occurring. This phase can last, for example, 24 to maybe 72 hours after a grain overload. Inside the hoof, things are already starting to go wrong.
Scary. Then what?
Then comes the acute phase. This begins with the actual onset of lameness, usually within about 72 hours of the insult. The horse is clearly painful. But crucially, at this point, there is typically no radiographic evidence, no sign on x-rays that the coffin bone has started to displace yet.
So painful, but the structures are still holding positionally speaking.
Essentially, yes, or the displacement is too minimal to see radiographically. Then finally, we have the chronic phase.
And that's when things get really serious structurally.
Yes, this phase is defined either by clinical signs persisting for more than 72 hours, or when we see clear evidence of P3 displacement coffin bone displacement on radiographs. That means rotation or sinking.
Rotation or sinking. Okay, we need to talk about those. So how do you actually catch this in a horse? What are the diagnostic clues you look for?
Diagnosis involves piecing together a lot of clues, like detective work. We start with a thorough history from the owner.
What kind of questions?
We're looking for recent events. Did the horse get into the grain shed? Sudden access to lush pasture? Any recent illness like diarrhea or a fever? Did a mare just foal? Was the horse recently given steroid injections? Did it have a period of excessive work on hard ground?
Checking all those trigger boxes we talked about.
Exactly. And is there severe lameness in another limb? We also look at chronic signs. Has this horse had laminitis episodes before? What breed is it? Some are more predisposed to metabolic issues. Is the horse overweight? Does it have that crusty neck?
Looking for those EMS or PPID signs.
Right. Then comes the physical exam.
And what does that tell you? What do you see or feel?
On physical exam, the classic stance is often telling that sawhorse stance. Horse tries to get weight off its toes, forelimbs extended forward, hind limbs camped under the body.
Trying to shift weight back.
Correct. We'll feel the digital pulses in the arteries running down the pastern. Normally they're faint, but with laminitis they become strong, bounding, easy to feel. There's often increased heat in the hoof capsule itself.
Inflammation.
Yes. And they're usually very painful when we apply hoof testers, especially over the toe area, right in front of the frog.
Okay. And the lameness itself?
The lameness is typically severe, grade 3 to 5 out of 5. They're very reluctant to move, sometimes refusing to walk at all. Turning in tight circles is excruciating for them.
Sounds awful.
It is. And depending on the cause, we might see other signs. In those systemic inflammatory cases, the horse might have a fever, or toxic mucous membranes, brick red or purplish gums.
Signs of sepsis.
Right. Whereas for endocrinopathic cases, we'll be looking for those signs like obesity, the crusty neck, or maybe a long curly hair coat that doesn't shed properly if it's PPID.
So a lot of external signs point you in the right direction. But to truly confirm what's going on inside that hoof and see the extent of the damage,
Yeah.
you really need imaging, right?
Absolutely. Radiography, x-rays is essential. It's non-negotiable for both diagnosing laminitis properly and, crucially, for monitoring its progression or response to treatment.
What views do you typically take?
We take specific, standardized views. A lateral medial view side to side is critical. We often place a radiopaque marker, like a thumbtack or wire, on the front of the hoof wall so we can measure things accurately from the image. We also usually take a dorsopalmar or dorsoplantar view, looking front to back.
Okay. And what are you looking for on those x-rays? What are the key findings?
There are several key things. First, we look for laminar widening. That's an increased distance between the front surface of the coffin bone, P3, and the inner surface of the dorsal hoof wall. Suggests swelling or separation.
Okay.
Then we measure for rotation of P3. Normally, the front surface of the coffin bone should be pretty much parallel to the dorsal hoof wall. Rotation means that angle has increased, the tip of the bone is pointing down more.
The bone is tilting downwards inside the hoof.
Correct. But here's where it gets really critical. We also look for distal displacement, which is often called sinking.
Sinking. That sounds bad.
It is very bad. This means the entire coffin bone has moved downwards, sunk deeper within the hoof capsule relative to the coronary band. We measure the distance from the coronary band down to a landmark on the coffin bone, or we look at the depth of the sole underneath the tip of P3.
And why is sinking so significant?
Because sinking is a crucial insight. It indicates severe, wholesale, acute lamellar detachment. The entire suspensory apparatus has failed catastrophically. It's not just a localized failure at the toe, like with pure rotation. It's a widespread collapse.
Meaning the prognosis is much worse.
Much, much worse. Poor to grave prognosis typically associated with sinking. We might also see remodeling changes on the coffin bone itself over time, like a ski tip appearance at the front edge, or sometimes even gas pockets within the laminae indicating tissue death, necrosis.
So the x-rays really tell the tale of the internal structural damage. Are there other imaging techniques that vets sometimes use?
Briefly, yes. For some chronic cases, venography can be useful. You inject contrast dye into the digital veins and take x-rays to see the blood supply to the laminae. Helps assess vascular damage and healing potential.
Okay.
And advanced imaging like MRI can give amazing detail of the soft tissues, even very early changes before they show on x-ray. But it's expensive, not widely available, and usually requires general anesthesia, which has its own risks in a laminitic horse. So x-rays remain the workhorse.
Got it. Beyond the hoof itself, what about blood tests? What can they reveal?
General blood work, like a CBC and chemistry panel, can sometimes show signs of systemic inflammation or dehydration, especially in those SIRS-type cases. Might give clues about the underlying cause.
But not diagnostic for laminitis itself.
Not directly for laminitis, no. But for suspected endocrinopathic laminitis, endocrine testing is absolutely critical. It helps confirm the underlying metabolic issue.
Like testing for insulin problems.
Exactly. We can measure resting insulin levels. But often, a more sensitive field test for insulin dysregulation, or ID, is the oral sugar test, the OST.
How does that work?
You give the horse a measured dose of something sugary, usually Care-Lite corn syrup, orally after fasting them briefly. Then you take blood samples at specific time points, typically 60 and 90 minutes later, to measure the insulin response.
Looking for an overreaction.
Precisely. An exaggerated, prolonged insulin response points strongly towards insulin dysregulation, a major risk factor for laminitis. We also test basal ACTH levels, especially in the autumn when it's most sensitive, to help diagnose PPID. We have to be cautious, though, about using the dexamethasone suppression test in actively laminitic horses, as giving dexamethasone could potentially worsen things.
Right, because steroids can be a trigger. Makes sense.
Exactly.
Okay, we've covered the what, the why, and the how we find it. Now for the crucial part. Management. How do you even begin to turn the tide against hoof failure?
Right, management. It's incredibly complex, often frustrating, and definitely requires a true multidisciplinary approach. It's a team effort. Veterinarian, a skilled farrier, and a committed owner. Everyone has to be on the same page.
And the goals.
Yeah.
What are you trying to achieve immediately?
The immediate goals, especially in that acute phase, are several-fold. First, alleviate the intense pain. Second, prevent or minimize any further displacement of the coffin bone, stop the rotation or sinking. Third, identify and correct or remove the underlying cause. And fourth, promote healing of the damaged laminae.
Okay, so step one. Eliminate the cause. What does that look like in practice?
It depends on the cause, of course. If it's grain overload, that means potentially gastric lavage, stomach pumping, and giving activated charcoal to bind toxins in the gut. If it's lush pasture, get the horse off it immediately.
No negotiation there.
None. For retained placentas or sepsis, aggressive intravenous fluids, antibiotics, anti-inflammatories, treating that primary systemic illness is paramount. For supporting limb cases, you have to aggressively treat the primary lameness in the other limb to allow that supporting limb some relief. And if it's drug-induced, discontinue the offending glucocorticoid if at all possible.
Makes sense. Get rid of the trigger.
Yeah.
Then you absolutely have to address the pain, right? It sounds agonizing.
Yes, pain management is paramount. Non-steroidal anti-inflammatory drugs, NSAIDs, are a mainstay. Flunixin meglumine, which is Banamine, is commonly used, especially for anti-endococcin effects in SIRS cases. However, phenylbutazone, or bute, often tends to provide superior pain relief, better analgesia, for the hoof pain itself.
Okay. Bute for pain. Any concerns with NSAIDs?
Yes, we always have to monitor for potential side effects, especially with longer-term use, like gastric ulcers or kidney damage. For really severe pain, sometimes NSAIDs aren't enough. We might need to add opioids like butorphanol or morphine, or even alpha-2 agonists like xylazine, sometimes as a constant rate infusion for more steady pain control.
Stronger stuff.
Yes, and another really useful tool for pain management, especially initially, is regional anesthesia. Doing a palmar or plantar digital nerve block, numbing the nerves to the foot, can provide excellent temporary pain relief.
Why is that so helpful?
Well, firstly, it makes the horse much more comfortable immediately. Secondly, it allows for a better physical examination of the foot. And critically, it makes it possible for the farrier to potentially apply therapeutic shoeing or trimming without causing extreme distress.
Ah, okay. Facilitates other treatments. And what about the mechanical support for the hoof itself? You said that was crucial.
Absolutely crucial, right from the start. The goal is to support the bone column and reduce stress on the damaged laminae. First, deep, soft bedding is essential. Sand is often ideal because it conforms to the foot, but deep shavings can also work. It encourages the horse to lie down more and provides cushioning when standing.
Makes sense. What about devices on the feet?
Immediate hoof support devices are vital. We need to provide support to the back part of the foot, the frog and sole area, to help unload the front part where the damage is often worst. Simple things like thick styrofoam pads cut to shape, sometimes called a lily pad, taped securely to the foot, can work well initially.
Styrofoam.
Yes, insulation styrofoam. It crushes down and conforms. Or using dental impression material, DIM, backed into the back of the foot. The idea is to support the frog and sole. Often, we also want to elevate the heels slightly.
Why elevate the heels? Seems counterintuitive, maybe.
It helps to reduce the tension exerted by the deep digital flexor tendon, the DDFT, which pulls on the bottom of the coffin bone. Reducing that pull can help prevent further rotation. So heel wedges might be part of the initial support package.
Got it. Reducing that DDF2 pull.
And then therapeutic trimming by an experienced farrier is essential, often done early on if possible with pain management. The goal is usually to back up the breakover point, making it easier for the hoof to roll forward and potentially remove pressure from the sole directly beneath the tip of P3 while ensuring the heels and frog are well supported. It's about realigning things as best as possible.
A lot happening mechanically. And what about the ice? I've heard about ice boots being almost miraculous if used early.
Cryotherapy or cold therapy, yes. This is highly effective, but only if started very early, ideally during that developmental phase before lameness starts, or right at the beginning of the acute phase.
Why is it so effective?
The cold has several benefits. It causes vasoconstriction, reducing blood flow and delivery of inflammatory mediators to the laminae. It dramatically reduces the metabolic rate of the laminar tissues, decreasing their oxygen demand. And importantly, it inhibits the activity of those destructive MMP enzymes we talked about.
So it slows down the whole damaging cascade.
Exactly. The method involves continuous limb immersion in ice water, kept very cold, around 0 to 5 degrees Celsius, or using specialized ice boots that circulate ice water or maintain contact with an ice slurry.
How long do you need to do it for?
It needs to be continuous or near continuous for a significant period, typically recommended for 48 to 72 hours, or potentially even longer, up to 5 to 7 days for high-risk sepsis-associated cases, as long as the risk factor persists. It's labor-intensive but can make a huge difference if implemented correctly and early enough.
Okay, that covers the emergency phase.
Yeah.
But what happens once coffin bone displacement has occurred? In the chronic phase now, the game changes, doesn't it?
It absolutely does. Once P3 has displaced and you're dealing with chronic laminitis or what we might call established hoof failure, therapeutic farriery truly becomes the cornerstone of long-term management.
The farrier takes center stage even more.
In many ways, yes. The goals of therapeutic farriery in chronic cases shift. Now it's about trying to realign the hoof capsule relative to the displaced P3 as much as possible over time, protecting the damaged, weakened laminae, relieving any pressure on the sole, especially under the tip of P3 where it might be close to penetrating, preventing further displacement, and promoting the growth of a healthier, more normally connected hoof wall from the coronary band down.
That sounds like a huge challenge. How do they achieve that? What kind of techniques or shoes are involved?
It requires immense skill and experience from the farrier, working closely with the veterinarian and regular x-rays to guide the trimming and shoeing. Techniques can vary widely depending on the specific case.
Like what?
Sometimes, in severe cases of rotation that aren't responding, a surgical option called a deep digital flexor tenotomy might be considered. That involves cutting the DDFT to completely release its pull on the coffin bone.
A drastic step.
It is usually reserved for salvage cases. More commonly, you'll see techniques like dorsal hoof wall resection, removing a section of the front hoof wall to relieve pressure and drain any trapped infection or serum.
Okay.
But the mainstay is often continued, carefully adjusted sole support using specialized pads or shoe modifications like heart bar shoes, reverse shoes, or wooden shoes, designed to load the back of the foot and unload the toe. And enhancing breakover is key, using rolled or rockered toes on shoes to make it easier for the horse to move off that foot with less leverage on the damaged laminae.
So it's all about meticulous, ongoing adjustments to the hoof mechanics, guided by X-rays.
Precisely. Regular, frequent adjustments based on radiographic progress are critical.
But you still have to deal with the root cause, especially if it's metabolic, right? That doesn't go away.
Absolutely. Addressing the underlying cause becomes a lifelong management strategy, especially for endocrinopathic laminitis. This is non-negotiable for long-term success.
What does that involve for, say, an EMS horse?
It means a strict, lifelong, low non-structural carbohydrate diet that's low sugar and starch. Hay often needs to be tested for its NSC content and potentially soaked to leach out sugars if it's too high, aiming for usually less than 10% NSC.
That takes dedication.
It does. Aggressive weight loss is crucial if the horse is obese, usually through dietary restriction initially. And then once the horse is sound enough, gradual controlled exercise needs to be reintroduced as exercise improves insulin sensitivity.
Are there new medical therapies that can help with these endocrine cases, beyond diet and exercise?
Yes, thankfully there are. For medical therapy in EMS cases, levothyroxine is sometimes used off-label to help kickstart weight loss and improve insulin sensitivity. But here's where it gets really interesting and promising. Newer drugs called SGLT2 inhibitors are showing immense potential.
SGLT2 inhibitors, what do?
These drugs, like velagliflozin, which is now approved for horses in some regions, work by making the kidneys excrete excess glucose into the urine.
So the horse pees out the extra sugar.
Basically, yes. By getting rid of excess glucose, it helps to lower blood insulin levels significantly. And since high insulin is the trigger for endocrinopathic laminitis, these drugs can be game changers for managing these high-risk horses. Very promising development.
Wow, that is interesting. What about for PPID horses?
For horses with concurrent PPID, the medication pergolide is the standard treatment to manage the underlying pituitary dysfunction, which helps control ACTH and downstream effects, including potentially improving insulin regulation in some cases.
Okay. And for supporting limb laminitis, is there anything specific beyond treating the primary problem?
Besides aggressively treating the primary lameness, it's about intensive prophylactic support to the good contralateral limb before it develops laminitis, if possible. Heel elevation, sole support on that limb from the outset can sometimes help mitigate the risk, but it remains incredibly challenging.
And ongoing pain management for chronic cases.
Yes, chronic pain can be a significant issue. Long-term NSAID use might be necessary, always at the lowest effective dose, and with careful monitoring for side effects. Sometimes adjunctive pain medications like gabapentin or tramadol might be added to help manage neuropathic pain or provide multimodal analgesia.
A multi-pronged attack on pain.
Exactly. And then rehabilitation. If the horse becomes sound and stable, it's a slow, gradual return to controlled activity. It's a very long road.
And unfortunately, complications can happen along that road.
Yes, chronic laminitis can lead to complications. Subcellular abscesses are quite common, developing under the sole due to bruising or compromised tissue. More severe complications include rupture of the deep digital flexor tendon or the worst-case scenario, the coffin bone actually penetrating through the sole of the hoof.
Oh no, that sounds devastating.
It usually necessitates euthanasia if that happens. It's a devastating endpoint.
This all sounds incredibly challenging for both the horse and the owner. What's the long-term outlook? What generally determines the prognosis?
You're right, it is challenging, and the prognosis for laminitis is highly variable. It really runs the gamut from complete recovery in mild cases to permanent debilitating lameness or, unfortunately, euthanasia in severe or complicated cases.
What makes a difference?
Several factors weigh heavily. Early diagnosis and aggressive, appropriate intervention are absolutely critical. The sooner you start effective treatment, the better the chance. The underlying cause matters too.
How so?
Well, Endocrinopathic laminitis, if the underlying insulin dysregulation and diet can be strictly managed long-term, often has a better prognosis for survival and pasture soundness compared to severe SIRS-associated laminitis following something like toxic colitis or supporting limb laminitis. Those often carry a poorer outlook.
And I imagine the severity of the coffin bone displacement seen on x-rays makes a huge difference. You emphasized sinking earlier.
Absolutely. The degree of P3 displacement is a major prognostic indicator. Rotation only, especially if mild to moderate, generally has a better prognosis than sinking. Distal displacement, sinking, as we discussed, indicates massive failure and carries a poor to grave prognosis, especially if there's separation at the coronary band or if P3 penetrates the soul.
That sinking really is the catastrophic marker.
It truly is. That's the key radiographic insight. When we see significant sinking, it tells us the damage is widespread and severe. Other factors include the horse's response to initial treatment and, importantly, owner compliance and financial commitment.
Because treatment is long and expensive.
Often very prolonged, intensive, and costly. The quality of the ongoing farriery and veterinary care available also significantly impacts the outcome. Access to experienced professionals is crucial.
So with all that complexity, cause, displacement, owner factors, is there one thing that gives you the clearest picture of a horse's prognosis?
It's interesting, isn't it? What's fascinating here, and perhaps a bit counterintuitive with all our diagnostics, is that the severity of the lameness itself, how much pain the horse is showing, its reluctance or inability to move, often remains the single most useful prognostic indicator in real time, regardless of some other factors.
So how much it hurts tells you the most.
In many ways, yes. It reflects the current state of inflammation and mechanical instability most directly. Of course, we combine that with radiographic findings and the cause. But lameness severity is paramount for assessing immediate welfare and likely outcome.
So breaking it down then, general outcomes.
Okay, generally speaking, mild cases, maybe obel grade 1 or 2 lameness with no significant P3 displacement on x-rays, often have an excellent prognosis for full recovery and return to previous function with prompt treatment.
That's good news.
Moderate cases, say with mild to moderate rotation but no sinking, might have a good to fair prognosis for achieving soundness, potentially returning to some level of work, although maybe not elite performance, requires diligent management.
Okay. And the severe ones.
Severe cases, those with significant rotation, say over 15 degrees or any degree of sinking, have a guarded to poor prognosis for long-term soundness and sometimes even for survival. Euthanasia due to intractable pain or irreversible hoof damage is unfortunately common in this group.
That's sobering. Specific numbers.
Some studies suggest horses with more than about 5 degrees of rotation or any sinking are unlikely to return to their previous level of athletic activity. And as I said, 15 degrees rotation often carries a guarded prognosis for survival, grave for soundness. And supporting limb laminitis often carries the poorest prognosis overall because the primary problem in the other leg often limits options.
So even for the horses that do recover, it sounds like it's a lifelong commitment to prevent it happening again.
Indeed. That's critical to understand. Laminitis, especially the endocrinopathic form, is often considered a chronic disease, or at least indicates a chronic underlying susceptibility. It requires lifelong vigilance, meaning careful diet management forever, maintaining appropriate body weight, regular skilled farrier care tailored to that horse's needs, and constant monitoring for any early signs of recurrence. Prevention is key once a horse has had an episode.
We've certainly taken a deep dive into the complexities of equine laminitis today, from its microscopic origins in those delicate laminae, right through to its profound, life-altering impact on a horse's life.
It's a condition that demands respect and understanding.
And while it's undeniably a challenging, often heartbreaking condition, really understanding its nuances, the causes, the mechanisms, the treatments, it empowers us all, vets, owners, farriers, to provide better prevention and management.
It truly highlights the delicate balance within these magnificent animals, how systems are interconnected.
Absolutely. You know, when we look at the incredible strength and intricate design of a horse's hoof, it really is a marvel of nature. But maybe, just maybe, its very complexity is also its vulnerability.
That's a profound thought.
So here's something to ponder. How does recognizing this delicate balance, this potential vulnerability within the marvel, transform our understanding of how we care for these magnificent animals every day?
Something definitely worth thinking about.
Indeed. Food for thought until our next deep dive.